I'm happy to have this discussion. I thank you guys for inviting me, and I'll also admit I didn't know that it was a debate until about a day ago. So mine's mostly just evidence-based, and it's not so much. It's a little bit more balanced instead of just picking certain articles. But nonetheless, where to stop, in this decision-making process, right? So these are my disclosures. I do work with companies and have designed systems that you may see pictures of here. I'll do my best to point them out if I think they're relevant to the discussion, but I do think we would agree that it's relatively agnostic as well. So there's probably three keys I want you to take away from at least my portion of the discussion. One is that we come to a common understanding about some of the mechanics in the cervical thoracic junction, right? Two is defining some of the forces that drive our decision-making as surgeons, okay? And then three is trying to get you to apply a more consistent framework to your decision-making, and we'll use that framework specifically in this use case of C1, where to stop, C7 versus T1, T2. And that's really the heart of this debate. And we want in every debate for there to be right answers and wrong answers. That's the nature of debates. It's the way they're established. It's the task we take on when we're asked to give debates. But we need to understand that it's really not black and white in terms of a clear issue. There's lots of shades of gray in between. There's lots of, well, it depends. And I think as we talk about this in the discussion section, there's a lot of times where you're going to tell yourself, well, my decision on stopping a distal construct is a, well, it depends decision, right? It depends on a lot of things. And I think, Rick, you laid them out at the very beginning before your slideshow even started, right? You talked about a lot of the factors that come into play. I'm going to rehash them in a minute here. But in terms of the cervical thoracic junction itself, there's some literature, but not an overwhelming amount of literature defining the motion characteristics at the cervical thoracic junction. There's a lot in the subaxial spine, especially as we kind of laid the groundwork for disc arthroplasty, but not as much in the cervical thoracic spine. But what I would leave you with is two notions. One is that the cervical thoracic junction is stiffer in rotation and inflection extension compared to the remainder of the subaxial spine. So it's a stiffer segment. It is a transition zone from flexibility to relative rigidity in the thoracic spine, and that there is motion at the cervical thoracic junction at C7, T1. So it is a non-zero motion. There is motion there. So you can't ignore the fact that extending fusions does remove motion, and Rick mentioned the implications potentially on PROs. But you can also argue that it's a relatively marginal loss of motion when you're talking about multi-segment constructs, right? We're not talking about a C6 to C7 versus a C6 to T1 fusion. We're typically talking about multi-segment constructs. And so in that setting, the loss of motion at C7, T1 is probably marginal, okay? Non-zero, but marginal. So here's my framework for thinking about this situation or thinking about these conundrums, right? This is based on a couple books which I've referenced in the corner, which are well worth a read. But there's basically four forces that drive your decision-making, right? That drives everybody's decision-making, and specifically applying it to the surgeon population. You're thinking about, on the right side, problems and solutions, right? So what's the problem you're facing, and what's the solution you're trying to enact? And on the other side, it's the friction. So this is when I break down questions in my mind. I'm asking myself, C7 versus T1. I'm framing this discussion as, what's the problem? What's the solution? And where's the friction, right? Where's the friction in my ability to make this decision on a consistent basis? So what's the problem at stopping at C7? This is going to be a little bit repetitive from what Rick had pointed out, is that distal junctional failure is real. There are construct forces that are applied at the cervical thoracic junction when you stop at C7 that are not normal. And it is predictable, right? I think there's plenty of literature that demonstrates that junctional failure at below an instrumented C7 segment is predictable, but again, it depends. It depends on bone quality, it depends on sagittal alignment, local and global sagittal alignment, it depends on T1 slope, it even depends on upper thoracic kyphus versus lower thoracic kyphus. It depends, okay? But we know that stopping at 7 is a more predictable source of distal junctional failure. What about adjacent segment disease? There's always this concern about stopping at 7. Am I going to develop an adjacent level issue at C7, T1? And again, there's a transition zone, so I think we intuitively want to say that it will, but the literature doesn't actually bear that out reliably so. There is some work overall that suggests that reoperation rates for all cause is higher if you stop at C7 compared to going to T1 or T2. So all-cause reoperations may be higher, but specifically around ASD, a little tough to say it's a definitive. And then there is fixation strength. Rick, one thing, I agree with almost everything you talk about. I don't think a C7 lateral mass screw is great fixation compared to a pedicle screw. So I do think the type of distal construct you have matters. And I think there's no doubt that you get better fixation with T1 and or T2 pedicle screws compared to C7. So fixation strength is a problem when you stop at C7. Is it a clinical problem? It depends. It depends. What's the problem at stopping at T1, T2? Again, motion preservation. So we talked earlier about the fact there is non-zero, although maybe marginal motion at the C7, T1 junction. Is that a problem? The PROs would suggest no. It would suggest equivalency, at least what's been reported, that there's not a substantial decline in PROs by extending beyond the C7 level. There is absolutely greater morbidity. Rick pointed that out, and I think there's a couple of other meta-analyses that demonstrate length of stay, blood loss, operative time being higher in an upper thoracic construct versus stopping at 7. That should be intuitive. You're doing more work. It's going to take more time. You're going to bleed more. The question of clinical significance comes into play, and no impact on PROs as far as we can tell, so is there a long-term impact for that added surgical morbidity? There is historically a question around the technical challenges of connecting your constructs down to the upper thoracic spine. I think the days of that are gone. We've got industry sponsors and partners that are in the room next door that are happy to show you their solutions for these technical problems that we faced over the last 20 years. And I think a lot of systems right now are really robust and are really designed to allow for relative ease, again, to remove that friction, right, from extending down to C7, T1. So I do think you can stop at C7. But these are the warning signs. This is where I would agree, and I think Rick and I are in agreement on this one. If there's cervical thoracic stenosis, you should not stop at C7. If there's spondylolisthesis at C7, T1, or T1, T2, you should not stop. A little bit of a soft call, but if there's substantial facet arthropathy at 7, T1, you probably don't want to stop at C7, especially in a long construct. I think revisions, when you're talking about revising people, when you're talking about deformity correction, whether it be mild or more severe deformity correction, when you're talking about conditions like ankylosing spondylitis where loads and forces are massively abnormal relative to normal physiology, stopping at C7, again, I don't think is a wise move. I think you want the security, right, to sleep at night and for your patients to have a lower revision rate of getting to the upper thoracic spine with good fixation. I look at sagittal alignment. We talked about this as well, right? Individuals with bad sagittal alignment, you can look at that as a C2 plumb line. You can look at it as your C2 SVA relative to T1 slope. You can look globally more and more now, thanks to the brilliant minds in the CSRS. I'm thinking about upper thoracic kyphus and about mid-thoracic kyphus. I'm trying to temper it so I don't start fusing everyone down to T5 or T10. But it's starting to come into play as we think about these situations. So I would summarize here, a couple slides left. Stopping at T2, we know for sure these are known facts. These aren't arguable, I think. Stronger distal fixation, a lower overall revision rate, maybe a lower ASD rate, but can't be proven. There is definitely greater blood loss or time and length of stay, but is that clinically relevant? No change in PROs or construct-related complications by getting down to T2. So this is, in my mind, a really interesting case. Rick, this looks a lot like the cases you showed. It's an individual with myelopathy, not a lot of radiculopathy, not a lot of neck pain, really well-maintained alignment on MRI and on CT, not a lot of facet arthropathy, little stuff, but not too bad. Upright x-rays would suggest that they're relatively well-balanced. They're a little positive, but not terrible. But overall, really well-balanced. They have a favorable C7 pedicle, which I showed on the CT earlier. They're lordotic. This is like the perfect person to stop at C7 T1, or sorry, to stop at C7, and maybe great for a C3 to 7 laminectomy infusion like Rick had mentioned. But in my practice, this is a person who's perfect for a laminoplasty, right? If I'm looking at all those perfect radiographic characteristics, all those perfect balance characteristics, all those perfect imaging characteristics, I'm thinking this individual might be great for a laminoplasty instead. And what I've noticed a trend overall in my practice, and I wonder if this reflects others in the room, is that the trend line is to do more complex cervical fusions in patients who need fusions. But in my patients who would probably do well back in the day with a C3 to 7 instrument fusion, I'm now thinking about a laminoplasty instead, right? So that overall, my fusions are moving towards upper thoracic constructs, but I think it's mostly or partially driven by the fact that my old fusions are being shifted into laminoplasties. And so we're going to see this transition. It might reflect what we're seeing nationally as well. Thank you very much. I appreciate your time.